Hi, everyone. Welcome to today's webinar, Implementing TF-CBT for Children with Complex Trauma. My name is Chad Severs, and I'll be your webinar moderator for today. And our presenter, Dr. Ben Siegel, is with us, and I'll do some introductions here in just a bit. But before we do that, I just want to tell you a little bit more about my program, ARBEST, and kind of what we do. So Arkansas Building Effective Services for Trauma is a state-funded program at the UAMS Psychiatric Research Institute. And our aim is to improve mental health services for children who have experienced trauma from events such as abuse, natural disasters, and family separation. We work really closely with their state child advocacy centers and other providers to build a trauma-informed mental health system. And we're probably best known for providing training to mental health professionals and treatments that are effective with helping children recover from trauma. And so if this is an area of training, child trauma is an area of interest to you, we have a YouTube channel, Facebook page, newsletter, and I'll kind of give you some more details here in a minute about that. I'm going to do a couple housekeeping announcements. So this webinar is an hour and a half. Our typical webinars are only an hour, so I just want to kind of remind everyone about that. It's an hour and a half. But we do want you to ask questions during the presentation. So we'll probably handle those at the end, but feel free to type those questions in as they come up. And if you'd like to earn a CEU, it's actually 1.5 CEU, so I'll be sure to change that. Just stick around to the very end. We'll have a code that's given, and you'll enter that into a survey after the webinar, and I'll provide some more instructions. And as I mentioned earlier, check us out on YouTube. We'll record this webinar and post it there at a later date. And you can like us on Facebook, where we frequently post about upcoming trainings, topics around child trauma, and things like that. So I'm going to turn it over to Dr. Ben Siegel. Dr. Siegel is an associate professor here in the Department of Psychiatry at UAMS. He's also a licensed psychologist. And he's a national TF-CBT trainer. So not only a lot of you have probably seen him in action and training here in Arkansas, but he also does trainings across the country. So we're very fortunate to have Dr. Siegel and give a warm virtual welcome to him. All right, it's all yours.
All right, welcome everyone. It's a great day to discuss TF-CBT and talk about TF-CBT. Sorry, I'm just figuring out the mouse as we go. So it's a good day whenever you get to talk about TF-CBT, and we're going to talk about sort of implementing TF-CBT for kids and adolescents with complex trauma. Of course, this presentation is designed for folks that are fairly familiar with TF-CBT. I see a lot of names of the attendees I know from our Arkansas ARBEST TF-CBT training. It's going to take your sort of foundational knowledge in TF-CBT and how to implement that and discuss the nuances of working with kids and families with complex trauma histories and presentations. So we will be covering a few main topics today. First, we're going to get on the same page or define complex trauma, what it is, what are the symptoms, what does it look like. We're going to focus a bit of time on clinical decision making, as this will be a theme throughout today that trauma history does not always equal trauma symptoms, and trauma symptoms doesn't always mean trauma treatment or TF-CBT now. And so the clinical decision, the assessment is incredibly important to help guide treatment and for treatment planning purposes. So we'll spend some time there. And then the bulk of the training will be discussing TF-CBT and implementing TF-CBT with children with a complex trauma presentation. So first, with definitions. Chronic trauma, I know many of you are familiar with this, but when we talk about chronic trauma, we are referring to the experience of having experienced multiple traumatic events, whether it is one trauma type that occurred over long duration, sexual abuse over several years, or multiple and varied events. such as physical abuse led to being removed from the home, foster care, and while in foster care, a tornado went through. Sort of the chronic nature of the trauma over a longer period of time, or multiple traumas, we'll call chronic trauma. And what we tend to see is that chronic trauma, the impact is seen as cumulative, such that the more trauma symptoms, the more impact. And we do tend to see that, again, the more chronic, the more impact across domains. Oftentimes more than just PTSD and trauma symptoms, we may see challenges in development and social skills and so forth. Complex trauma describes both the exposure, typically meaning that a child has experienced chronic trauma, and the complex trauma piece with the exposure is usually that the individual that engages in the trauma or causes the trauma is someone that was supposed to teach, support, model, be that safe, supportive caregiver that was supposed to model appropriate social skills and emotional regulation and boundaries and create a both physically and emotionally safe environment for the child. And when that is the case, we might define that history as complex trauma, that it is chronic trauma complicated by that lack of caregiver support, safety, teaching, where that caregiver in often cases is the one that is the reason, the cause behind the trauma. And what we do tend to see that, with chronic trauma experiences, because of what the world and caregivers are sort of teaching the child at oftentimes a young age, is that the world is unsafe, the world is unpredictable, the world is unstructured, danger, bad things can happen all times, there is no one to keep me safe. And, in those situations, coping defense mechanisms develop, where a lot of the energy and development is solely focused on safety, survival, and that's a wonderful, purposeful thing that, if we don't survive, then we don't survive. And so the energy, the focus becomes on being aware of, when things may be unsafe or I might be in danger. And, that has sort of a cascading effect on sort of biology, brain development, so forth, that the focus on safety and danger becomes the primary focus, and then less development of the body and mind is focused on, the ABCs, the 1, 2, 3s, social skills, managing emotions, interpersonal relationships and partnerships, and making appropriate choices and all those things. Where the primary focus is staying alive and safety. And so what we can see that kids who experience sort of that complex trauma history can have developmental gaps, and that trauma can impact the child in many ways. Of course, PTSD symptoms like intrusive thoughts or avoidance of people, places, sensations that remind them of their trauma, depressive symptoms, hyperarousal, difficulty sitting still, all those things that you're very familiar with. But we can also see difficulties sort of across domains and functioning sort of beyond sort of that classic, what we'll call PTSD diagnosis and symptoms. And we may see more severe affective dysregulation, interpersonal difficulties, behavioral difficulties, self-esteem, high-risk behaviors, dangerous behaviors, more deeply ingrained beliefs about themselves and the world that are reinforced by trauma and rooted in trauma. And so we typically do see, when kiddos have had complex trauma experiences, we can see PTSD symptoms and these other domains impacted. It makes sense why we see this impact is, again, kids are reliant on their caregivers to teach and model, and they pick up things in their environment, and that shapes them. And so the important piece around complex trauma exposure versus complex trauma presentation is that complex trauma exposure doesn't necessarily mean that there's going to be a complex trauma presentation. And what that means is if we're doing TF-CBT, for instance, TF-CBT is a fairly past-focused intervention where the child talks about previous experiences with adequate or enough details to get thoughts and feelings, learning coping skills, practice skills, safety skills, emotional regulation skills. But TF-CBT, for it to be the appropriate treatment, kiddo has to have what we'll call those classic PTSD symptoms that I talked about a moment. They may also have the things on this slide, like the severe affective dysregulation and poor social skills or interpersonal difficulties or high-risk dangerous behaviors. That's the additional. It's sort of PTSD classic plus. And so, thinking through when we're talking about implementing TF-CBT for kids with complex trauma, they have to have the exposure and current complex trauma presentation, meaning they need to have PTSD symptoms, those classic PTSD symptoms plus these. Now, I am not saying that, these deeply held beliefs or difficult, dangerous, risky behaviors are rooted in trauma. That's not what I'm saying. I'm just saying that for TF-CBT to be an appropriate treatment to address these, the kiddo does have to have those PTSD symptoms like intrusive thoughts and beliefs and avoidance and hyperarousal for TF-CBT to be appropriate. Now, I will say that we have research on TF-CBT and implementing it with kiddos with complex trauma. And so we can say quite confidently that TF-CBT is effective for reducing both PTSD, sort of those classic PTSD symptoms, plus these other difficulties that go along with PTSD that we'll refer to as complex trauma presentation. So we see improvements in emotional regulation and better choices and better social, interpersonal relationships and skills and improved depression and self-esteem. But it does oftentimes take nuances and a little bit of extra sort of focus on training or attending presentations to see how TF-CBT might be a little bit different for a kiddo with complex trauma presentation versus a kiddo with not. And so we are going to focus on clinical decision making, really talking about that again. Trauma history doesn't always equal trauma symptoms, and trauma symptoms doesn't always equal TF-CBT or trauma treatment right now. Now, an assessment, of kiddos should be fairly broad. We're not just looking at PTSD symptoms. We want to know about other behavioral difficulties, social emotional difficulties, high-risk behaviors, challenging behaviors, the caregiving sort of environment. Are they supervising, monitoring? We want a sort of a broad assessment to see and help us think through the difficulties that the child is having or the family is having. Does it fall under the trauma umbrella? Or is it something separate? Or has it taken on a focus of its own that may need to be a primary treatment? So, early assessment, we're assessing broadly trauma and other symptoms, and we're assessing throughout. And when we have the results of assessment, particularly in the cases of complex trauma, we're thinking, what is driving the train? Is trauma driving the train? For instance, a child has complex trauma history, child has PTSD symptoms, and child is using substances. In lots of cases, substance use can be a coping strategy that the child has implemented to become numb or cope with trauma reminders. And so in that case, yeah, I would certainly say, you know, well, addressing, monitoring, covering substance use within TF-CBT, we could see some improvements on substance use as we replace some of those sort of negative coping strategies with more positive ones, like psychoeducation around trauma reminders and teaching relaxation skills and so forth. But sometimes child may start using substances to cope with trauma reminders, but the substance use can take on a life of its own, and child may become dependent on use of substances and engaging in lots of risky behaviors to obtain substances and risky behaviors while using substances. There may be legal issues and so forth, and that may be a case that although clinically you see that, oh, it's sure rooted in trauma and I'm seeing PTSD symptoms, but substance dependence may need to be a primary focus at the moment. That might need to be the focus on um, working to reduce the dependence on substances, maybe more focus on substance dependence treatment, because it's going to be hard to do trauma work if the child is high while in session with you. And so that might need to be the focus first, and always being trauma informed. And along the way, when the child is making gains on reducing use of substances, we can transition to TF-CBT. And a lot of times, it's hard to figure out, do we need to focus on the depression, the cutting, and the suicidal ideation as a significant concerning area? Do we need to go in first with TF-CBT and address sort of depression, suicide ideation within that? Or do we have significant concerns about suicide attempt and depression that we may need to work on reducing some of those symptoms, either through a short-term hospitalization, referral to a physician, or even working on behavioral activation skills that would be helpful, scheduling pleasurable activities, understanding emotions, working on and building self-esteem, throwing in some psychoeducation about where some of this depression came from. So it's a complicated kind of decision, but the bottom line is you're going to be doing a lot of similar things. So let's say, if I asked you, what would you be doing if you've never heard of TF-CBT? You're probably going to be doing a lot of safety work, some psychoeducation, helping to understand trauma, working on depression, working on anxiety, and those are a lot of things that we're going to be doing in TF-CBT. But for some kids, stabilization, safety work may need to be the primary focus for a while, and then transitioning more to TF-CBT. So talking about a couple examples. So you got a 16-year-old girl frequently sexually abused by stepfather from age 12 to 15, daily use of marijuana and occasional use of other substances, suicidal ideation with significant symptoms of depression. So depending on, your assessment, your intake, meeting with this child and environment, your primary sort of treatment focus or what's driving the train could be very different. Certainly, sexual abuse could lead to PTSD symptoms, and child tried to cope with PTSD symptoms through use of substances. We can certainly see suicidal ideation and depression related to PTSD symptoms. And you can certainly make an argument, in this case, that TF-CBT and reducing trauma symptoms will decrease depression and use of substances. But we may, find out this daily use of marijuana is more that the child is constantly high, and the marijuana use has had the child involved in juvenile justice and is at risk of losing a foster home because of some of the choices and interaction that happen when the child is high. And the symptoms of depression are very concerning. You may need to work on depression stabilization first and transitioning to TF-CBT. How about a 13-year-old boy with a history of physical abuse and domestic violence, oppositional behavior at home, at school, bullying, starting fires, and threatening mother? In your assessment, wanting to know a little bit more around the history of physical abuse and domestic violence. How long ago did that occur? Has the child had PTSD treatment before, maybe TF-CBT? Again, trauma history doesn't always mean present trauma symptoms. Are these new behaviors? Are these behaviors that have become exacerbated lately if there's a gap between trauma history and trauma symptoms? We could have a child that is not having PTSD symptoms, just having more generalized behavioral difficulties. And if we're not seeing trauma symptoms, certainly trauma is not driving the train, and we might need to focus on the oppositional defiant behaviors and supporting the caregiver and child and making better choices. And so it's not an easy thing, but just knowing that we can conceptualize kiddos very differently and not just jumping into TF-CBT because there's a trauma history, that we need to be cautious. And again, asking you this question, kiddos are going to come in with complicated histories and more than just trauma symptoms. And I will tell you honestly, it's going to be hard to decide, TF-CBT or not, or do I need to work on these other things? And in most cases, you can ask yourself, let's just pretend I've never heard of TF-CBT, right? Just didn't know anything about it. Kiddos coming in with behavioral difficulties and making poor choices and impulsivity and what seems to be a lot of trauma symptoms and difficult emotional regulation. We've got some concerns around safety in the home. You're probably going to do something like working with a caregiver to improve safety. You're going to work with the child on some coping strategies, identifying, emotions, intensities, relaxation, coping, helping them make better choices. And along the way, if you're worried about trauma, you're going to probably do some education on trauma. And so in a lot of cases, you may start if you're not sure what's driving the train. It sure seems like it's all interconnected, but you don't know. You can start with practice skills, the safety stabilization skills, and over time, kiddo may engage. As you build some trust, kiddo may open up some more, and you may see some of these other behavioral difficulties or the antecedents for behavioral difficulties or relationship difficulties as trauma reminders. And if that's the case, certainly you're going to transition and continue into TF-CBT, but other cases, get to know the kiddo and there may not be PTSD symptoms. And in that case, you're going to continue to work on, stabilization, safety skills, and work on these other difficulties. So let's move on into implementing TF-CBT for kids with complex trauma. And I want you to have some background things in your mind, just as you're thinking about how to implement TF-CBT. And there should be a slide that you're familiar with, or a concept that you're familiar with from previous training. But TF-CBT is components-based and phase-based. The practice acronym, we have the components in the practice acronym that we generally, follow in order, starting with psychoeducation and parenting skills, relaxation, and so forth. But there are also phases. And the practice skills that I've been talking about is the stabilization phase. And oftentimes within the stabilization phase, there's a large focus on safety. Because we really can't make much progress in trauma work if there isn't safety, both physical and emotional. And so the stabilization phase is incredibly important. And working through the stabilization phase, transitioning to the trauma narration phase and processing, which is where the child tells their story with appropriate amount of details, thoughts, and feelings, and you're identifying those inaccurate, unhelpful thoughts, those trauma-related thoughts, and you're helping the child go through a process of guided reconsideration to help them have more helpful and accurate thoughts. As you're working through the processing sort of portion of TF-CBT, you're transitioning to the integration phase, helping the child contextualize, make sense, look more forward, or be more present with their life, helping them, identify future trauma reminders, work on safety work, continue to work with the caregiver and child in restoring a relationship and talk about difficult things, doing sex education, enhancing safety work, things like no-go tell and hula hoop space and all those wonderful things that are good skills for kids to learn. And generally speaking, in TF-CBT, we think about phases. We're spending a third of our time in each phase. And so, if you look on the left, the time, the amount of sessions, 8 to 16, maybe 20, is your typical TF-CBT case. And along the way, you're always doing parenting skills and you're doing gradual exposure. But let's just take, 15 sessions as our guide. That means we're spending 5 sessions in stabilization phase, 5 sessions in trauma narration phase, and 5 sessions in integration consolidation. So it's roughly equal. That also should tell you a few things, that the stabilization phase, it's not towards mastery. It is understanding, it is movement, it is improvement, but we're also building the skills and stabilization, a language between us and the child that we're going to use, that we need in trauma narration phase, as the child details and talks about their experiences with trauma and identifies their feelings and thoughts. And we have a language to help make sure the child is not moving too quickly, but also not moving too slowly. So they can tell us when their cell phone battery is super low and they're about to become overwhelmed. And so we, pause, the work that we're doing and practice some relaxers and coping skills. And that also a reminder that when we're done with trauma narration and we're working on processing, there's a whole third of the model left to help build up the child to be prepared for the future and succeed. But in cases with complex trauma presentation, there are a few differences. You'll notice on the left, the number of sessions has gone up, 16, 25 sessions. Maybe more typical. We're still doing parenting skills. We're still doing gradual exposure. But you'll notice on the right, we're spending different proportions of time in different phases. So let's just do 24 sessions because it's easy for me to do math. That means we're spending half our time, 12 sessions in stabilization and safety, building rapport, trust, sometimes going a little bit slower with the gradual exposure piece, maybe teaching coping skills and stabilization skills first to everyday situations, and then infusing psychoeducation and more talk of trauma reminders. And so, rightly so, we spend more time in stabilization because kids with complex trauma presentation, they tend to be more complicated and they need more help with stabilization. But what you also notice is, although we're spending more time on safety and stabilization, we're not necessarily spending more time on trauma narration. So, in this example, we went from 15 to 24 sessions. Before we had 5 sessions in trauma narration phase, now we have 6. So just a reminder that just because the child's trauma experiences are more chronic in duration and diversity, it doesn't necessarily mean we're going to spend more time in trauma narration. And of course, we can't forget, we have to be doing gradual exposure sort of throughout. Hopefully you've all seen a slide like this before, but the solid line on the top, that's our goal, that we're slowly talking about trauma in each session. First, within psychoeducation, teaching skills, applying it to trauma reminders, how you can use relaxation skills to trauma reminders, emotional recognition intensities related to trauma reminders, and continuing into trauma narration. And what we do not want to do is the bottom line. We're doing a wonderful job of teaching skills like relaxation and coping, but we're not applying it to trauma reminders or talking about trauma. And so you get to trauma narration and there's huge sort of increase in potentially trauma symptoms or exposure. And guess what? Child doesn't show up for a session. Or child sort of has quite a few PTSD symptoms sort of come back. And that's on us because we have not done a good job of gradual exposure. Another piece that is incredibly important to talk about with kiddos with complex trauma histories and complex trauma presentations are that, unfortunately, kiddos may have some previous experience with a therapist that has not gone well, or with child welfare, or been in residential, or had a variety of adults in their life that have not been supportive and safe and caring and appropriate to trust and let their guard down. And they may have lots of caregivers that have come in and out, and why should you be any different? And so, being aware of that and having some conversations very early on in treatment to try to identify both concrete and perceptual barriers to engagement. When we talk about concrete barriers, these are things like family barriers around they don't have gas money to come to sessions, or scheduling difficulties with work, um, or the family has several kids, and arranging sort of for daycare or babysitting might be challenging for the caregiver to participate in sessions. Those are concrete barriers. Some of those, through telehealth that a lot of us are using, transportation, things like that, have been reduced some. But what we do know from research is that it's the perceptual barriers that keep kids and caregivers from engaging. And perceptual barriers are more internal. It's views, values, concerns that are more unique or individual to that person. And, that could be mistrust of the system, or it could be related to um, views of the therapist as not understanding their culture, or views within a culture that mental health is not what we do. We don't express our emotions. We need to be tough. That's how we stay safe, both in their culture, in their community, within their family. This is stuff that is not talked about outside the family. It's also you know um, discussions around concerns around racism and sexism, and are you going to understand my religion, or teach things in a way that makes sense to me? These are all value-based, culture-based sort of potential barriers that we need to address. And I think some general strategies, and I'm sure you all have some good strategies to work with this. But I think a big thing is we got to let kids and families tell their story. Sometimes vent. You've been in therapy before. You've had lots of providers. Like, what's worked? What hasn't? I don't want to be another provider that will be in and out of your life and not helpful. Same thing with caregivers. Sometimes it's the separation from the system. Well, this person says I have to be here, or else I'm not going to get my kid back. Um, finding ways that you can align with the family, as opposed to just a member of the system that, in the caregiver's view, may be out to get them. But also thinking about, caregivers' kids' own history. Caregivers may come in with their own trauma symptoms, and participating in trauma treatment may be very challenging. This is where we kind of default to our core counseling skills, unconditional positive regard, warmth, being just human beings and caring, um, and letting kids know what to expect. What is TF-CBT, and why do I have to do TF-CBT? Making your case through psychoeducation, or using assessment results and using their own language. This is what you reported to me, and this is why I think we need to do this treatment. Sometimes it's looking for the side entrance, just those small opportunities where a kiddo or caregiver might let their guard down a little bit, and not head directly into we need to do this, this, and this, but when they have a moment of maybe pondering, what if this did happen, or what would it mean if, where we can build upon that, where there's just a little bit of emotion, or a little bit of an opening, and building upon those small openings until we've made movement. Now, thinking about going through the practice acronym, within psychoeducation, we all know how to do psychoeducation. But the thing you may want to add for the kiddos and caregivers is helping them have an understanding how trauma might be related to not just trauma and trauma symptoms and trauma reminders, like nightmares or flashbacks, or reenactment behaviors, but how could it be related to some of the other difficulties, the depression symptoms, or feeling like no one will ever love me, or substance use, or gang involvement, or even how kids may become involved in commercial sexual exploitation. Trauma histories may put kids at more at risk, and for some kids, even though it is absolutely not okay, gang involvement may fill a need that has never been there for a child, an affiliation, and so forth. And so understanding how some of the behaviors the child is having serve a purpose, meet a need, and that when we're going to be discussing trauma, if connected to these symptoms, we're likely to see decreases in behaviors as well. And oftentimes this is hugely important for caregivers. I know lots of you have caregivers come in where they're just fed up. They don't know what to do. They're really struggling with behavioral difficulties and arguing with the kiddos, and they're at the point where they're just not enjoying their kiddos. And at their wits' end and feel like they've tried a lot. And so sometimes helping them see their kiddos not as a bad kiddo, but more of my child experienced some bad things, and that has led to some challenges, and the child is trying to adapt and learn some ways to cope, but they're not working, and so let's figure out some other ways that might work. Now, again, not in all cases, we're going to have, in the cases of, a particularly chronic trauma history or complex, we may not have at the beginning a caregiver that is safe or appropriate to be involved in TF-CBT treatment. That's where we're flexible. Caregiver is broadly defined. It is someone that is providing caregiving. It doesn't have to be a bio parent or a relative. It may be there's a therapist or support staff in residential, or someone that just is really sort of invested or has a role in caregiving, and that may be our starting caregiver, just to help the child build some self-esteem, build some control over managing trauma reminders. But again, trauma reminders, can't emphasize that enough, that is going to be a big and primary focus of our work within Prac Skills and through TF-CBT throughout. So making sure in psychoeducation we are covering trauma reminders. And oftentimes we are finding, again, with kiddos with complex trauma, we are doing more safety work in the beginning, and that's appropriate. Both physical and emotional safety. Sometimes it's working with caregivers around technology. Technology has been really helpful in this time of pandemic to kids to be able to come to sessions or attend school at home, but it also has its challenges. I'm sure you're all aware it is very easy for a kiddo to stumble upon or purposely stumble upon adult content, or get in trouble with social media or sexting and not necessarily knowing the consequences or understanding the content. So conversation with the caregivers around supervising modern electronics, social media, talking about safety plans. If there is a concern about suicide ideation, how are we going to monitor? What are some skills and a coping plan when the child is feeling down? If there's cutting behavior, how are we going to handle that? And of course, building up a system around the family, both the caregivers for social support and peers. That we do know negative peer influences can have a big impact on choices and functioning. And so doing some social skills work or peer work on, how can we change the peer group or help to identify a supportive, healthy peer group with both the child and caregiver. And, again, needing to have safety work first, to have stability, practice skills work, but also certainly in place before we do things like trauma narration. And again, thinking through trauma, many of you have probably heard me use the filing cabinet analogy to describe trauma. So bear with me if you've heard it before, but thinking through your memory is like a filing cabinet. And in typical situations, something happens to you, your memory system files those memories in order. So, let's say, it's 2020, prior to the pandemic, you took a vacation. And, so it's 2021 and like everyone's got vaccinated and things are safe and you're thinking about planning a vacation again. So in your filing cabinet, you're like, okay, let's think about my past, vacations and what we did. And so, okay, 2020. So we find in our nice organized filing cabinet, vacations, V for vacations, pull it out, 2020. Okay, we went to Disney World and, this was good, but it was, just a year ago, maybe we do something else. What went well, what didn't, how did I plan or buy tickets or plane tickets? You get the information you want. When you're done with it, put it back in the file, close the drawer, it's there. But that's not how trauma memories are stored. Trauma memories, the hippocampus, which is the memory system, goes offline to protect, to sort of focus on the here and now and staying alive and staying safe. And so, after trauma or danger, that system may go back online and, work to process and store those memories in order. But for kiddos, some kiddos, there is not a safe place or an opportunity to process or a safe caregiver to support. And so their files are stored out of order and fragmented, and there are pieces everywhere. And so when a child has a trauma reminder, it opens up that filing cabinet and flashes and images that are kind of all disconnected flash to the child, and it's overwhelming. That's a trauma reminder. And so what does the child do? Close that filing cabinet as quick as possible. That's avoidance. And the next time filing cabinet gets opened, trauma reminder flashes, close it even quicker. And so if we think of trauma and TF-CBT, what we're doing slowly in TF-CBT is we're slowly opening up that file cabinet drawer. And we're allowing some of those trauma reminders to come out. But as they come out, we're pairing it with safety and coping skills to help the child gain control and reduce that emotion. So slowly over time, we're opening that filing cabinet more. And the child is gaining more and more control. However, if there is not safety, the child's in the middle of their trauma, opening that file cabinet drawer is going to be very overwhelming to a child. And so we need safety work. And they're not going to be able to open up that filing cabinet because their focus is, filing cabinet is past. I'm not safe now. My trauma is still ongoing. I can't deal with the past. Just going with this analogy a little bit further, we're opening up the filing cabinet, putting files in order through the trauma narration. So it is that nicely organized 2020 vacation folder. Thinking through the trauma themes, those are kind of at the bottom of the filing cabinet, underneath all the files. And kids aren't able to access and understand where some of those trauma themes, those inaccurate, unhelpful thoughts around, I'm not a good kiddo, adults will never keep me safe, the world is dangerous, they're always going to give up on me. And kiddos can't access those until we put the file cabinet in order, which is trauma narration. And so, using that analogy, but the importance of safety work. And safety work can take many forms. For some kiddos, it's early sex education conversations, conversations about consent. Are they sexually active in, a consensual relationship? Having conversations about birth control and STIs and STDs, having conversations about appropriate qualities of partners. We've worked with pregnant teens. Some of the safety work is having conversations around prenatal care and, discussing options related to, adoption or raising the child and not adopting, and things like that. Of course, there's substance education, there's working on self-harm, it's enhancing communication kinds of things, doing things like no-go tell. As many of you know, I also train and work a lot with kids with problematic sexual behavior, so we might be teaching kids rules around private parts and boundaries or sexual behavior rules. Anything that is causing emotional or physical concerns around safety, we're going to discuss. Discussions around sexual orientation, gender identity, gender expression, values within the family. What messages are the kiddos getting in their community, within their family around safety to be able to express their identity and sexual orientation, and getting questions answered if they have questions as they navigate some really difficult parts in their lives for all kids. And so that's all safety work. And we need to focus on that and having some of those conversations early. Moving on to parenting. Parenting, as you've probably all heard me say before, parenting is more broad than just teaching things like labeled praises and natural and logical consequences. It's building up a relationship between the child and the caregiver, that the child is safe to attach, have a relationship with the caregiver, that the caregiver is participating in treatment, understanding trauma and the impact of trauma on their kiddo, but also supporting the child to use practice skills and make appropriate decisions and support the child talking about their experiences through a trauma narration, helping with safety work. And unfortunately, not all caregivers are ready to do that. They may come in with their own trauma symptoms, their own views around shame or guilt. How could I have not known? This happened because I'm a bad parent. My child's ruined just like I was when I was sexually abused. They're never going to be happy. Some caregivers, have views that the child is purposely being bad. It's not trauma related. They're just a bad seed, and I need to discipline. And only, corporal punishment kinds of things and taking away will work. Whether that comes from a cultural value or family value or whatever it is, that's what they're comfortable with, that's what they're using, or it's a place that they've got to, that's all I have left. That's all I see working. And so you might need to pull in some engagement, motivational interviewing strategies, allowing a safe environment for the caregivers to share, what's getting in the way of them participating or hearing some of these difficult things the child's gone through. Or in the case where they are just using some inappropriate, harsh parenting strategies and you're really wanting to work on improving the relationship and attachment and helping the child feel that they can go to a caregiver when they're in times of stress. You might do things out of sort of that motivational interviewing, motivational enhancement kind of world, like good supervisor, bad supervisor, or the pros and cons of changing. I'll go over one just for the sake of time, but good supervisor, bad supervisor is a good one to go through. And it's just basically having a caregiver think through, in your life, have you ever had what you would call a bad supervisor or mentor or someone that was just kind of in a oversight role of you? Think about that person and share with me the characteristics of that person. And usually the caregiver will say they micromanage and they're always on my butt. They'd catch me when I'm making mistakes. They wouldn't praise me for working hard. Well, how did that sort of motivate you for work product and showing up to work and things like that? Well, I got sick. I wasn't happy. I just didn't work really hard. I would call in sick a lot. Well, let's switch to a good supervisor doing the same thing. And, the characteristics are usually all the opposites of what they just said before. And then, sort of, making the connection that, we all share sort of in our relationships and our interactions some qualities of good supervisors and bad supervisors. And, I want you to think of, sort of the strategies, the relationship with your kiddo related to their behaviors and so forth, sort of, thinking about your good supervisor, bad supervisor, sort of what characteristics are you using, with your child that may fall under more of that bad supervisor, good supervisor. And for some caregivers, this is kind of an aha moment, like, oh, that's how I felt, and I'm being that person. And so, then working on, okay, wanting to be more of that good supervisor. Let's talk about how we get there, what's getting in the way. Pros and cons of changing is a very similar strategy, that there are both pros and cons of staying the same and pros and cons of changing. Oftentimes, caregivers come in with out of whack, that's a clinical term, sort of expectations on what is normal behavior for a child versus problematic or inappropriate, oftentimes around things like this concept of remorse. They're just not remorseful. They don't show any guilt around their behavior. Or, they should just know and be motivated to do good things without me having to praise them or let them know that they're doing a good job. I never got that. But sometimes it's educating them on really the capacities of their individual child, and being comfortable with things like moral reasoning and Kohlberg stages of moral development, and understanding that a lot of the kids that we're working with, they're in a very concrete stage of development, and we need to help them understand abstract thought and that their behaviors can impact others, because a lot of kids really into adolescence and further, they're just very motivated by their sort of self-focused individual experiences. And it's a skill just like anything else that needs to get developed. And also, thinking in a trauma-informed way, where some of these behaviors, may have had their source in trauma. Again, where we're looking in parenting skills, you have to have a foundation. And starting with attachment, predictable, positive communication, and environment that is safe, and building upon the build-up skills. Catching the child being good, rewarding, hugs, things like that. And then lastly, the focus should be less on, consequences for breaking rules. But that's not always where caregivers are coming in. And so it is a big switch to work on some of these foundational kinds of skills, which is new for them or uncomfortable. And so thinking about how can we start there. And again, functional behavior analysis, a behavior, and helping the caregiver in times where it's appropriate and is linked that a lot of behaviors that we may see, the antecedent may be a trauma cause and a trauma reminder. And that may mean we might need to intervene slightly different than a strategy that is not. And so, really working with the caregiver to educate and understand and help them see a behavior is just a behavior. There's something that happens before, and there's always something that happens afterwards. And how can we intervene on both sides, and preferably on the before side? Relaxation, for complex trauma, be flexible. Lots of kiddos have they're savvy in therapy. They've been taught lots of different things. But the bottom line around relaxation is, I don't care what it is. If it works, do it. It's relaxing. And of course, teaching those skills, whether it's going out for a walk in the woods or listening to music or, running on the treadmill to get out energy. Of course, we're doing things like yoga and grounding and mindfulness and progressive muscle relaxation and diaphragmatic breathing, belly breathing, because that helps as well too. But expand sort of your repertoire or, the different tools that a kiddo could use to relax. Because the bottom line is, if a child is having a trauma reminder, we want to have as many skills as possible. And maybe they're not like the go-to strategies that work for some kids, but being flexible around what works to help this kiddo relax. And again, having adults in their life model those same skills and understanding those skills. So, emotions in kids with complex trauma, they can be a range. Some kids feel feelings very strongly, and we have to slow down and help them understand feelings. Other kids they're just numb. Feelings are unsafe. I only feel anger. Anger is safe. So we might need to work on, what's behind the anger. If we have an angry mask, externally, what's going on internally, it might be different. Some kids, we may have to, even 15, 16, 17-year-olds, we have to go back to sort of the basics. What are feelings and how do we know when we are feeling feelings? Maybe starting with physiological sensations and then labeling it with what that sort of emotion is and starting very slowly, because an emotion itself can be a trauma-related reminder. When I start to feel, bad things happen, and so I don't feel. And so you might have to go slower and teach those skills, reinforce, help build in non-trauma related situations where things can be okay, practicing before and afterwards to understand emotions and intensities. Just may have to go slower. The idea that, helping them have control over their emotions or their mind or their thoughts. And, this is where we do, thought interruption, that idea of having remote control for your head. That, if you're having a trauma reminder or thinking about something that is causing a lot of sadness, related to trauma, well, I got a remote control in my head. I can think about something else, just like I have a remote control of the TV. Your remote control may switch to a safe place or positive imagery. Or, that switching your mind may also switch to doing, something in reality. Like, okay, this is a cue to me that says, okay, I need to keep myself busy. I'm going to go read a book or play video games, or whatever it may be, to help gain control over my thoughts, that I don't have to let it spiral out of control, that I can understand the thought, I can sit with it, I can find a way to cope with it through relaxation, or changing my mind, changing the channel. Cognitive coping, you're all familiar with this. There are some skills and strategies that I think are very helpful for older kids. You all should, hopefully, you're aware of the What Are You Thinking team, the Healthy Thinking team. This is just I think, an adolescent-friendly or mature school-age kiddo understanding of thought themes. Like emotional reasoning or all or nothing thinking, that you're familiar with from other areas, but it's a way to help kids understand that, oh, lots of people have sort of these thought themes, and it's okay that if I understand I have that thought theme, I can think about something differently. And so knowing within this part, and this is where it's important to realize cognitive coping, this thought piece, we are not addressing trauma-related thoughts here. That particularly in the case where we have a very deeply held, wrapped in trauma sort of thought, we're not going to have much luck getting at that thought until we do trauma narration. Thinking through that filing cabinet again. If that thought is at the very bottom of that filing cabinet, and we're just slowly getting to a place where we're opening up the drawers, we still have to put those files in order. And so, knowing that for this component, it may be more focused, and it should be more focused on helping the child understand what thoughts are and that they can change their thoughts in certain situations, and that we're going to get to trauma-related thoughts very soon, transitioning to trauma narration and cognitive processing of the trauma narration. Now, of course, remembering, we may need more time with the caregivers to work on their own related, inaccurate, unhelpful thoughts. This is the What Are You Thinking team that is available on tfcbt.org. Emo Emily, Emotional Reasoning, Drama Queen Jean. The Healthy Thinking team, Affect Alfred. I love Pro and Con Ron, considering options, making thoughtful decisions. In this sort of cognitive coping piece, you may do more problem-solving, self-control kinds of things, helping kids do something like the stop technique. Stop, say how you're feeling, use some type of relaxation skill, identification of what your thoughts are. And if you would continue with that thought, could you have an alternate thought? If I act quickly on this situation, what would the outcome be? Are there alternative situations? that may be helpful just again to bringing all the practice skills together to help them gain control over making appropriate decisions. So I want to spend a little bit more time here in trauma narration and processing. And just some highlights around, again, with complex trauma, how might it be different? Again, remember it is gradual exposure. That we are slowly talking about trauma more, and even within trauma narration, there is structure. That there might be chapters, starting with about me, life before the trauma, what happened afterwards. Remember that it is not a goal of getting endless details about all the traumas the child has experienced. It's about getting enough details to get a sense of what occurred and enough details to obtain thoughts and feelings. And then shifting towards helping kiddos, reconsider those thoughts and feelings and make movements. This is where we are slowly putting that filing cabinet, those files in order, where lots of the past is impeding on the present. We're going back and we're clearing out the past so the child can be more focused on now and the future. It is an interactive process. It is process over product. There is something that typically you have at the end, whether it's a chapter book or a poem or a newspaper account. That is the product. The process is the more important piece. That's narration versus narrative. The narration is all the prep work, what happens between the lines to get to that final product. Now, preparing for trauma narration, making sure you've made some improvement on stability. That kiddo understands the coping skills, when cued, can use them, making sure there has been gradual exposure. That before you start trauma narration, you have at least basic details of the child's trauma experience. Not trauma narration details, but that it's been talked about. Like you've focused, you've done education on sexual abuse or physical abuse or foster care. The child, in some form or fashion over the course of your practice skills, has talked enough about what has occurred. Moving into trauma narration should not be the first time the child talks about what happened to them. You should have some basic sort of things. There should not be this big, huge elephant in the room. You also, kiddo, must understand what trauma reminders are. Again, depending on developmental level and age, we'd expect different things, but caregiver, child, understanding trauma reminders, and they understand the skills, and when cued or with support, they can reduce trauma reminders by use of coping skills, relaxation, and so forth. And that you have a good sense of their strengths, the things that they're more comfortable with, and the things that they're not comfortable with. If you know at this point, child does not like writing, we're probably not going to have the child write the trauma narration. But if you have a child that is just amazingly artistic and creative, we got to incorporate that. And so, starting trauma narration with any kiddo, but particularly kids with, more of this complex trauma presentation, making it tailored to their unique experience and comfort level is important. So at least have 3 potential ideas in your head of how you could do trauma narration and give the child choices. Again, giving them some control and choice, making it a little fun, making it a little different. Now, a couple other things to just remember when we're doing trauma narration with kiddos with chronic complex trauma. It is not having the child talk about all the traumas in their life in a lot of detail. It's more about, with kiddos with complex trauma, oftentimes it's more about what it has meant in the context and how it's impacted their life now and their future, or even how it's impacted their past, and getting at some of those trauma themes. And so we're able to do that by limiting the number of sessions devoted to coming up with details. And I'll talk about that in a moment, how to do that through things like timelines and so forth. If you've done enough trauma narration and enough TF-CBT with kiddos, and particularly kiddos with long histories of trauma and complicated traumas and complicated impacts of trauma, you'll start to see that your focus within trauma narration may be different for different kids. Some kiddos are highly avoidant, and talking about the details and putting the pieces in order may be an incredibly helpful part. Other kids, they may be able to give you the details, but there's just a lot of emotion tied to some inaccurate, unhelpful trauma-related themes. And so you may spend maybe less time in getting details, but more time focusing on those thoughts and processing. But of course, there are some kids that need both. So I'm not saying don't do like the detailed part or don't do the processing part for some kiddos, just the proportion that you spend in different pieces and energy and time might be different for different kids. Also, again, in the case where kiddos have had a lot of trauma, we don't necessarily need to focus on all the traumas in their life. And so this is where you've been paying attention through your practice skills and assessment, for the kiddo, what have they reported as the most impactful sort of trauma? Or the one that's caused the most impact or distress, or getting information from caregiver. And through the course of practice skills and identification of trauma reminders, have they focused on one trauma or one trauma type over others? Or is the child comfortable talking about some traumas, but they're highly avoidant of one trauma or others? If they're avoidant, I may want to focus more on the avoidant ones. And this is where you use your clinical decision. Sometimes kids need to start with traumas that are less impactful to understand the process and work up to a more impactful trauma. Some kids are like, nope, I'm ready. I want to get the hardest one over with, and we're going to focus on that, and then we're going to see if we need to talk about the others. So, giving kiddos some choice with some encouragement in one direction or the other. Now, again, remember the big picture, process over product. That, chapter books are the default, they are the fallback. That we can always do those. And as long as we follow the format of that chapter book, the structure, slowly talking more and more about trauma, building up maybe life before, about me now, eventually getting to the chapter or chapters on the traumatic events, and then afterwards, we can do that in a lot of different ways. And so you're only limited by your creativity. But you can also have, if you think of that chapter book, it's okay to have 3 chapter 3s. I probably wouldn't have more than that, maybe 4 at the most. But it's okay to have different chapter 3s, the chapter around the traumatic event and impact. But we are finding more and more that it is helpful for a lot of kids that have a chronic, complex trauma history, where you almost see in your sessions, and I know you all are familiar with these kiddos, where it's hard for them to give you a coherent timeline of their life. Because their whole life, honestly speaking, might be filled with trauma, or there are certain periods of life, more trauma versus others. And when you talk to them about their history, you just see sort of this disorganization, and you can just see the trauma reminders. And kiddo doesn't have the perspective or the context to make sense of it, or really allow for processing. And so for some kiddos, sort of that timeline of really creating 0 to 17 or however old they are, what are some good memories or some decent memories or periods of life, and what are their negative or difficult or traumatic experiences, and getting them down on a piece of paper, a really big dry erase board, or Word document or PowerPoint, to help the child see, well, geez, how did I get here? Eventually, well, given all of this, no wonder why I think adults are not going to take care of me or going to give up on me. Look at all these adults that have given up on me. And then, once getting out sort of this is the life, both good, neutral, and negative experiences, you may pull out 2, 3-ish traumas to do more of a chapter 3 on those. And oftentimes in the case where it's just these trauma themes throughout, you may quickly see that the traumas are connected. And even if they're not connected, there's an underlying theme. And so you can then transition to more of that cognitive processing. Now again, give choice, order as much as possible. Again, it's the child's subjective perception of what is important. It may not all be about what you think is the main traumatic event. It may be about what happened afterwards. The interviews, the separation from siblings, the concern around mom or dad, or my baby brother or sister that I was kind of the parent for. That might have been the worst part. And so the focus may need to be less on the actual details of the domestic violence in the home or the physical abuse or sexual abuse. And for the child, it's more about what happened afterwards. But over our course of treatment, we want to make sure we don't miss the hot spot or the worst moment or experience. And we may want to expand upon that a little bit more, just to make sure we're not missing any important thoughts, feelings, details that need to be talked about, or missing any sort of significant avoidance. Now, there's also a discussion around the impact of trauma could have impacted other behavioral choices, relationships, and sometimes the consequences of trauma and sort of negative coping strategies or maladaptive coping strategies have led to not the best choices or additional trauma. And so, does that belong in trauma narration? For some kiddos, yes. Some kiddos, no. So as I said before, I work with a lot of kids with sexual behaviors, problematic sexual behavior, and although problematic sexual behavior have a lot of origins and kids develop problematic sexual behavior for a variety of reasons, for a good chunk of kids, exposure to sexuality, modeling of sexuality or sexual abuse can be part of their story and can cause PTSD symptoms. And, as we know, PTSD symptoms, one of PTSD symptoms are reenactment behaviors. And what kids are modeled and exposed to by adults, the messages that are sent around what is okay and not okay, around private parts and body parts and sexual body parts, kids can engage in those behaviors that may be very similar to the behaviors, experiences they experience. And so the child may engage with problematic behavior with another child or sibling, and that is concerning and that is serious. But we may conceptualize that as part of the child's trauma story. And so for some kiddos, maybe the impact of trauma and feelings around, this is how I felt when I was sexually abused, and now my sibling or cousin or whoever may have the same feelings because of what I did. And for some kiddos, that might need to be part of the discussion. Or, they made some poor choices around using drugs and alcohol, and that led to a friend, being killed, maybe drinking and driving or substance uses, or a friend ODing. Is that part of the child's trauma story? And it's not an easy decision to see whether it's included it or not. The bottom line is the focus should be on the child's trauma story and reducing their trauma. And if that's part of the story and it's needed to process and work through to help them reduce trauma symptoms, we're going to include it. Now, there are lots of creative methods for doing trauma narration, and many of these we can still do through telehealth. Talk show interviews, media accounts, texting back and forth, using the chat box, pictures, drawings. Working with a kiddo, trauma narration was nothing but a playlist or a series of quotes, collages that signify different periods of life, creating a PowerPoint through telehealth, showing images, capturing electronic images, creating collages in a PowerPoint if we are doing telehealth. Poetry, taking the Color My World activity, which is, just the drawing of bodies and where you feel certain feelings, and maybe adding some thoughts, maybe that's different periods of life. Comic books. I tend to use a lot of comic books in doing backstories and psychoeducation on superheroes and comic book characters. Lots of them have a trauma backstory. Masks, using the concept of masks that, sort of on the outside, the world may see certain things, like I'm strong and, I'm a good kiddo and I get good grades and I'm happy, but internally, I'm depressed and I feel isolated and I'm thinking about hurting myself, and sort of maybe having masks for different periods of life and working towards having the internal mask match more of the external mask. And how do we get there? Again, you're only limited by your creativity and your fear of trying something new. So I think in general, the most meaningful trauma narrations I've done have been very creative ones. Sometimes it's been out of my comfort zone, but it takes some pressure off the kiddos because it's something that they're creating that's a little bit more fun. Now, moving on to processing, again, it's not necessarily the details of what happened, but the meaning behind it for lots of kiddos. And, that's where we're using those life narratives or timelines or, identifying those trauma themes related to themselves in the world. And we may need to spend some time processing through that and, building up the caregiver and the relationship to counter, or even with you as a safe adult, to counter that belief that all adults are going to give up on me and not be safe. We can go a long way in correcting experiences. And also having that time with the caregivers to be supportive and ultimately, hopefully, sharing a trauma narration with a supportive caregiver. Now, again, we're getting trauma-related thoughts through all sorts of areas, from, our assessment coming up through trauma narration, from, hearing from the caregivers, from the kiddos, and so forth. And, we're going to use our typical strategies, for kids and adolescents, Socratic methoding, sort of this idea of helping them come up with a process, just generally speaking, where there's more evidence for the more accurate, helpful thought than the unhelpful, inaccurate thought. And, with the time I have left, I can't really expand upon these a little bit further, but just one thought around this is it may not be possible in the short amount of time that we have in TF-CBT or within cognitive processing to undo a thought that took years to get to. And so being easy on ourselves, that we should not expect perfection. We should not expect that, kiddo believed this thought 100% before, and we shift it to not believing this thought 100% after a few sessions or activities on cognitive processing and using skills. And so we want movement. And so it is okay in some cases, knowing that you still have a third of TF-CBT left, to have movement and continuing to work on some of those thoughts, well past, closing up trauma narration and sharing. So know that it does not have to be perfect. We want movement. We oftentimes helping the kiddos understand, well, in my head, I know this, but it feels this way. That's a huge step. But getting over those feelings may take more time. That cognitive, well, I know it in my head, but my heart, I feel it differently. And so knowing movement, not perfection. Considering that, well, I could think about that. Yes, I understand that. I'm not there yet, but I can understand what you're saying, and I could see how I could think that way. That might be good enough for the moment. And then, of course, when you're done, you've discussed the worst experience, the trauma that's causing, the trauma symptoms. You've got reductions in trauma symptoms. You've made movement on some inaccurate, unhelpful thoughts. You're seeing the kiddo more organized, more coherent, often in their memories, and they're starting to see contextualization, the impact on the past on current functioning, and what it means for me now and in the future. And so making sure there is that wrap up. What have I learned? How am I different? What would I tell others? I used to think and feel this way. I think and feel this way now. I know that I still have this work to do. It doesn't have to be perfect. I'm slowly starting to trust adults, but it's hard for me because of what has happened to me before. And I've had a lot of unsafe adults in my life, but I'm working on that. And this is how I would know if a person is safe. Oftentimes in the cases, sort of wrap up and work that we do with kids, it's unfortunate that it's not unfortunate, it's just the situation where we may reduce trauma symptoms. There still may be other work to do. And, we may have a limited amount of time, to work with kids. Maybe if we're in a CAC, we reduce trauma symptoms and, maybe refer to another clinic, to continue to work on, additional relationship, social skills, behavioral kinds of things, or, kiddos transitioning from residential to moving to a group home. And so kiddo may have, different caregivers, they may have new therapists. And so, part of this, I think, integration, consolidation, moving into the last sort of phase within TF-CBT is, maybe doing a letter that summarizes your work in TF-CBT and the gains that have made, and having the child and the caregiver, if appropriate, talk through, this is what we still need to work on. This is what you need to know about me as a provider, that it may take a while for me to trust you. And so for those kiddos that there is going to be a new provider for whatever reason, again, helping them have control. So it's not like starting over again. Now, sharing. Again, I will be clear that sharing a trauma narration is not required in TF-CBT. We do want to work towards it when we have a safe and supportive caregiver, but also knowing that relationship and trust is an important thing to the kiddo. And, they need to feel comfortable and safe with the caregiver, and we need to make sure the caregiver is going to have the appropriate response. And so, kids may move at a faster pace than caregivers. You may share trauma narration later with a caregiver when they're ready. Or, caregivers may be at a different place because their own trauma symptoms. In some cases, maybe you share the last piece, the contextualization, consolidation, and have a sharing session where the caregiver can hear all the work that the kiddo's done and their improvements and things they still need to work on. And the caregiver can have conversations around, I really want to hear the whole story. But as you know, this is a shared trauma, and I'm in my own individual therapy, and I'm in the middle of telling my story, and I want to be able to be healthy so I can hear your story, and I want to hear it in the future, but I'm not there yet. But it's important for me to hear and tell you that I'm here for you. So there are clinical decision making around that. But if you have concerns it's going to go badly, that there are valid reasons why the child shouldn't share with a caregiver. Maybe in the case where we've just transitioned to a new foster parent a couple weeks ago. Yeah, it's reasonable for the child not to want to share their full story with a brand new caregiver. Additionally, we haven't had time to prepare that foster parent to hear a trauma narration. So just thinking through some of those things. If you have a mastery, don't forget, this is an important piece. It is optional. It's not required. Again, it is fun. It can get you out of your office. Conjoint sessions, we do these throughout. Not just sharing trauma narration, but really helping the caregiver and the child talk about difficult things. Oftentimes, restoring the relationship and safety, and building up the caregiver as the caregiver and the child as the child. And so these may happen early and often, and we're typically having quite a few more of these sort of in the closing pieces of TF-CBT beyond just sharing the trauma narration. planning for future trauma reminders, having discussions in the case where a child may have been sexually abused, teaching sex education to provide the basics and functions and answering questions, but also teaching in a way that the caregiver is able to talk about the values of their family and community that are important to them and continuing that conversation. And any other sort of general safety things, beyond, puberty and sexual orientation and discussions around, um, functions as private parts and where do babies come from and those kinds of things, but also broadening it to friendships and intimacy and partnerships, beyond just private parts and what private parts do and how private parts change. It is very broad, and that's what we want to focus on, building up that caregiver to take the conversations from us, that we may provide the detail and the content, but they continue that conversation. Now, again, given kiddos, often have a lot of comorbid or additional difficulties, beyond sort of those classic PTSD symptoms. We are talking about complex trauma presentation. How to talk through, managing safety around those other behaviors that may come up during different periods of life, different developmental areas. Birthdays, holidays where caregiver is no longer present. Talking through with the caregivers how to monitor, supervise. Are they aware of social media and the scary stuff is out there that kids can easily identify related to pornography and adult content? You're working through social skills, communication skills, continue to work on depression, is all part of enhancing safety. And so not forgetting, you're done with trauma narration, you're not done with TF-CBT. We're taking upon what we've been working all along and continuing in that vein and expanding. The importance of having a planned goodbye. Many of the kids that we work with do not have planned goodbyes. And so bringing up the idea a few sessions before, several sessions before you're thinking about graduation, to talk about what does it mean that this is someone I've opened up to and they are now not going to be in my life. Lots of kiddos don't get planned goodbyes, but I do think there is importance of having successful corrective experiences and planned goodbyes, building upon gains, celebrating however you can. I have a book that I keep that kiddos, a separate book for kids, book for caregivers, where they write messages for future clients, that are coming in that have been in their shoes, messages of support. And so that might be sort of the part of, my graduation kind of ritual, knowing that there still may be work to do, but they've successfully graduated from TF-CBT, and let's pivot. And of course, reassess. There still may be other difficulties even after we've, reduced trauma symptoms and TF-CBT has been a success. And so there still may be work to do. And you may have to pull in some trauma work every once in a while. But I really do think it's important, if you're going to continue with a kiddo, that you have that pivot. Celebrate the hard work, then help them shift and work on other areas. And we are in a challenging time for all of us, for pandemic, for stress, learning to do telehealth, stress around finances and managing kids and working from home and managing kids attend school at home. And hopefully what is a long overdue awakening on changing our cultural awareness and being more open and inclusive, regardless of gender and sexual orientation and identity and race and religion. And I have hope that we're going to continue these conversations, but we are in a challenging time. And I encourage you all to broaden your lens of trauma, historical, racial, intergenerational trauma. trauma related to COVID or coronavirus. Do not forget about that, but also practice your own self-care, because we all want to do good work, and we're living in a very challenging time, and many of us have lost our social supports and lost our own coping mechanisms. So making sure that we are healthy and strong for our clients. So I know I talked for a little bit longer than I planned. It is an hour and a half now. I am happy to stay on for a few minutes to come up and ask her any questions. I'm around in Arkansas. It is my focus and goal to provide TF-CBT support. That is my job. So do not hesitate to reach out to me or any ARBEST staff. Chad has some information to pass along getting CEUs.
Thank you, Dr. Siegel. So today's code is 1712, and shortly after this webinar, I will send an email out to everyone who attended. And so if you logged in, I already have your email, and so just be looking for that here in a bit. So again, just jot down the code of 1712, and if you're interested in getting a CEU, you'll need to enter that. So yeah, there were a couple of questions that did come in, and I thought I could ask Dr. Siegel a couple of those to you. And if folks have to leave, that's totally understandable. I'll just kind of leave the CEU slide up here. So a couple of questions for
just
yeah, go ahead.
Chad, before I forget, just thank you all for being on. And if you need anything, just let me know. I hope this was helpful. Help you think about some things, or even add to your already wonderful TF-CBT toolbox. So I hope it's been helpful. So let me know what the questions are, Chad. See if we can answer.
So a couple of folks asked just about resources in general, just about complex trauma, and that got me thinking about the TF-CBT consult page through the Medical University of South Carolina. I don't know if you knew of any other kind of your go-to complex trauma and TF-CBT resources that you found helpful.
Yeah, there are a couple. There are a couple good articles that are available, research articles and journals on implementation of TF-CBT with kids with complex trauma, and so we can send the links to those.
Perfect.
There also is the treatment application book, TF-CBT. It's a wonderful book where it talks about treatment applications to certain populations. So in its instance, they talk about kids in child welfare, kiddos with intellectual developmental disabilities, and there's a chapter on complex trauma. And so for any of you that just love TF-CBT, you drank the Kool-Aid and just like, I just want to soak up as much TF-CBT as possible, you can get it on Amazon.
Just that's the most recent version, right?
Yeah. There also is, many of you may have received the more revised TF-CBT manual from our trainings. There is a focus within that on complex trauma and implementing TF-CBT with complex trauma. And again, I'm going to blank on the full name, but it is by Tony, Esther, and Judy. It is the second version of the TF-CBT manual. And that is different than the treatment applications book.
And one more question, maybe we'll end with this one, is are there any kind of limitations that folks should be mindful of when they're creating their trauma narrative in the telehealth world? Anything that I think maybe we should think closely about using telehealth as kind of the modality?
Ooh, that brings up a whole lot. So I think, again, thinking through telehealth, if you are using telehealth, thinking through, from an agency, licensure, credentialing standpoint, making sure that any tool that you're using is confidential and protected, and that you have agency approval and you have, altered or edited, revised things like consent forms to use telehealth. We have put together a resource for TF-CBT. using telehealth. And so that is something that is available. It's 2 pages on our ARBEST website. It has some information on, how can you use telehealth to do trauma narration? And in most cases, you can make trauma narration through using telehealth function and look fairly similar to be in person. There are some caveats that you really need to have face-to-face visuals, to have nonverbals. So you need to be able to observe the client, and having features like being able to share your screen, pulling up a Word document where the child can see, maybe they're talking and you're typing. You can use the chat box. If the child's more comfortable typing, and then you can copy and paste that into a Word document. You could do things like, on Zoom, there is a whiteboard, where, the child could draw pictures, and talk about, the picture representing, certain periods of life, and having conversations and doing some notes on that. You could create a PowerPoint. So I think it's more about checking the boxes to making sure that the child's in a private location, that you're securing trauma narrations, that you're comfortable with technologies, to be able to do that. But lots of people have lots of success because we've had to, doing trauma narration through telehealth. But again, check out that 2-pager on our ARBEST website. There is a tab within TFCBT, the TFCBT National Certification page, tfcbt.org. There is a tab on telehealth for resources that are available. There is a webinar that is just fantastic. It's an hour-and-a-half long. It's free. Actually, there are 2 parts. One goes over all the logistic and procedural things about doing telehealth and TFCBT. The second part is going through the practice acronym, getting visuals around, what that may look like through telehealth. So I would encourage you to start there if you have questions about just TFCBT in general, trauma narration, and telehealth.
All right. Well, thank you for that information, Dr. Siegel, and we'll end it at that. Hope everyone has a great rest of the year, and hope to see you next month in January. And just have a great day, everybody.
Thank you, everyone.